user, you have to measure only the uncorrected visual acuity. If the patient isn't able to reach a good vision for far, you can go to the manual ophthalmometry. But in other words, you have to refract the patient as we all used to do in the 80 years. The near reading distance, all you know that for the restore is fixed between 35 and 40 centimeters. With Mplus, the best is from between 40 and 50, but it's also quite good at 35, 60, and 70 centimeters. I asked some patients that I operated no more than 2 months ago, and they were absolutely satisfied with the laptop, satisfied with the desktop, but when they sat at more than 80 centimeters, they had some problems with the computer. The most important result that I found with these lenses is the satisfaction of the patients. If the cornea is in good condition, just from the day one, they are very, very satisfied. Some surgical pairs, if you decide to work on the steepest axis, I think it's useful to place two conjunctival marks at 9 and 3 o'clock. The capsular axis size, according to me, is the best as 5 millimeters because there is no risk that also if there is some concentration of the capsular axis, the lens is difficult to disintegrate. It's important to rotate the IOL inside the bag, and if you make temporal side surgery, you have to put the IOL in a particular position when you place the lens on the cartridge. If you, in this case, if you are working on a left eye, we have to put the lens with this button in the proximal position, so the rotation is only of 90 degrees. The same and the opposite situation is when we work on the right eye. If you put the lens with the button in this other position, the lens has to rotate only in 90 degrees. Observation. There is a vertical coma. It's important to warn the patient about it. It is described as an inferior halo, and it disappears in time. A few weeks and it disappears. But it's not so important in terms of vision quality disturbance. Dr. Elio has reported some cases about tilting. I have to say that I haven't seen any tilting up to now, but anyway, they suggest of implant a capsular tension ray. This signal is very important. If you have a patient with a signal greater than 1 diopter, I think it's better to shoot with toric IOL, multifocal toric IOL by Mplus. The poor positioning is not so important. I have 3 patients with counterclockwise rotation, and they are normally able to read with no problem. There are some cases where the IOL was placed in the complete opposite position, and the patient are able to read it anyway. These are our findings about halos, glare, and poor positioning. We have 8% of halos, 4 of glare, and 3 patients with counterclockwise rotation. I have not seen any PCO in 1 year, almost 1 year of observation, and this is confirmed also by other doctors. Dr. Aramberi reported 6% of decentration, so it's very important to make a very good capsular axis, and I repeat, the sport is useful to implant the capsular tension ray. So again, in our our sample of patients, the Mplus showed an excellent and corrected visual acuity for almost all the instances, highly independent of spectral use, and with almost no neural detection time. Thank you.
I think that's very interesting. A couple of things that I would like to comment on. You always see an image of whatever's in the optic of the pupil. So you'd expect to see the halo inferiorly because the optic is, what is the power? 3 diopters?
Yes.
So you'd expect to see an inferior halo that would be 3 diopters out of focus, and that's what the patient's accustomed to. The couple of things. The first, in a normal eye, the pupil is descended about 0.3 of a millimeter nasally and about 1/10 of a millimeter down. So when the patient looks up close, the pupil constricts, and if the lens is absolutely in the center of the bag, it'll be a little temporal relative to the center of the pupil, so when it constricts, it'll come down into that optic a little bit better than it would if you had put it superior